Hello, this is Farah Douglas, President and CEO of the Liver Health Foundation. Thank you for joining us this evening. Liver Health Foundation is a California-based entity. Many of the members of our board of directors represent liver patients and caregivers. Liver Health Foundation's Medical Advisory Council has 30 members who are some of the best hepatologists and liver specialists in the United States. Our mission is to provide updated and accurate information on liver health, promote prevention of liver disease, advocate for quality patient care, and host community and physician-centered educational programs and events. To see the complete list of our 2022 program and events, please visit our website, liverhealthfoundations.org. I want to thank Dr. Robert Gish, who is the MC and host of tonight's webinar, our presenters, Dr. Sundaram from Cedars-Sinai and Dr. Khan from USC Keck. And also my appreciation goes to AbbVie and Exelixis for their support, which enables us to provide life-saving information to liver patients. Now I would like to introduce Phil Black, who is representing AbbVie, the silver sponsor for tonight's webinar. Phil, I believe we have a short video that has been produced by AbbVie. Let's watch it together. Thank you. Mr. Black, would you like to say a few words about AbbVie?
All right, thank you, Farah. Again, this is Phil Black. I am on behalf of AbbVie Hepatology. I appreciate you all allowing us to be here. One of the sponsors. And again, we appreciate the opportunity to sponsor you. My colleague Madeline couldn't be here, but I'm representing our team for this evening. So again, thank you, and we're proud to be a part of this.
Thank you so much. We appreciate AbbVie's help as well as Exelixis to allow us to bring this information to our patients. It is now my distinct honor to introduce tonight's MC and host, Dr. Robert Gish. Dr. Gish is a member of Liver Health Foundation's Medical Advisory Council. He is the adjunct professor of medicine at the University of Nevada School of Medicine in Las Vegas and Reno, adjunct professor of pharmacy at the Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD, and medical director at Hepatitis B Foundation, medical director of Asia Pacific Health Foundation. Dr. Gish is a fellow of the American Association for the Study of Liver Disease, the American Society of Transplantation, and the American College of Physicians. He was a major early contributor to decipherment methods for the detection of hepatitis B and C virus and characterizing its epidemiology and clinical presentation in humans. He was involved in studies that led to the genotype classification strategies and methods now in use worldwide. Dr. Gish, please start the program. Thank you again.
Thanks, Farah. Wonderful introduction. I'm very happy to be part of the Liver Health Foundation and the great service you provide across this beautiful swath of land from Los Angeles into the Inland Empire, all the way to Las Vegas. And I know there's people on from actually all over California and Nevada. So we're going to be kicking off this presentation. And if we could go to the next slide, that would be great. I would be delighted to introduce Dr. Sundaram from Cedars-Sinai. He's a associate professor of medicine, director of hepatology outcomes research, and very important, Vinay completed his medical school at NYU, followed by residency at University of Virginia, GI fellowship at Pittsburgh, and a transplant hepatology fellowship at Beth Israel Deaconess Medical Center, and serves as part of the AASLD acute on chronic liver failure special interest groups, and does many contributions to education and hepatology, moving things forward with a variety of wonderful publications, including outcomes and liver transplantation. We're now going to switch to Dr. Sundaram and his presentation today. We're going to be talking about liver disease, liver health, and cirrhosis. And we're really going to put this package together really to talk to patients, how to speak to patients and their family, how to speak to our colleagues in the hepatology community about that educational process. We're now going to change over to Dr. Sundaram. Welcome, Vinay, and we look forward to your presentation. I'll be back soon to introduce Dr. Jeffrey Kahn for part 2.
Okay, thank you for the nice introduction, and thank you to Farah and the Liver Wellness Foundation for the invitation to speak at this event. So my talk is going to be about an introduction to cirrhosis, and it's going to be it's going to be a rather short talk. It's going to mainly to just orient the audience with cirrhosis and liver disease. But I think the meat, the important part of this event is going to be the Q&A towards the end, which is where I think that we should focus our attention. But I'll start with kind of an introduction to cirrhosis. So the questions for discussion here. When I see a patient and they come to my office with a diagnosis of cirrhosis, these are really the 3 questions they have in mind. First, what is it? Second, how did I get this? What causes this? Particularly a number of patients who have said that I've never had anything to drink in my life, because the implication is that when you have a diagnosis of cirrhosis, it's self-imposed based on a history of alcohol use. And then finally, what does this mean for me? What are the implications? Do I need a transplant? Do I have cancer? Am I going to die from this? And these are all very important things which we need to be able to counsel the patient on so that they can successfully go through their journey after receiving this diagnosis. So what is cirrhosis? So the word cirrhosis was first used by a French pathologist, René Laennec, to describe the abnormal color of patients with alcohol use. So in fact, for a very long time, I would say prior to the new millennium, prior to the year 2000, alcoholic cirrhosis was actually also labeled as Lennox cirrhosis. And that in fact was one of the codes that was used to categorize a patient, was a diagnosis of Lennox cirrhosis. This comes from the Greek word meaning yellowish brown color, and it seems to represent the development of jaundice, which is yellowing of the skin or the eyes. But in actuality, what is it? What does this mean for you? So whenever you had a chronic insult to the liver, whether it's from alcohol use, from fatty liver disease, from hepatitis C, etc., this leads to chronic liver injury due to the sustained insult which is occurring. And unless that insult is somehow addressed, such as a patient with alcohol use stops drinking, or a patient with hepatitis C gets treated, thanks to medications which have been created by AbbVie, what happens otherwise, if that insult is not addressed, is that there is chronic injury of the liver cells, leading to death of some of these liver cells. Those are also known as hepatocytes. And now, as the liver attempts to regenerate itself, because many of you may have heard that the liver is an organ which can regenerate itself. That is partially true. So for instance, if you have a tumor in your liver and that tumor is cut out, then in that situation, yes, the liver can regenerate itself. But in the setting of a chronic liver injury, what is occurring here is that you have cell death occurring, but kind of at a more gradual or insidious level. And the liver is attempting to regenerate itself by the creation of scar tissue, also known as fibrosis. But the problem is that the scar tissue development is actually counterproductive, because what happens is that the scar tissue ultimately replaces healthy liver cells and also creates abnormal architecture of the liver. And the creation of this abnormal architecture, which we call as a nodular liver or a bumpy liver as opposed to a smooth liver, is consistent with the development of cirrhosis. So essentially, a diagnosis of cirrhosis means that there is severe scar tissue, also known as stage 4 scar tissue in the liver. Now let's expand upon this a little bit further. So here we have a patient with fatty liver disease, and I'm just walking you through the different stages of cirrhosis based on a liver biopsy. So fibrosis is something that we measure using what's called a trichrome stain, which stains blue, okay? So here we have a patient with fatty liver disease, but no fibrosis, because you can see there's no blue. Now, let's look at stage 4, which is the equivalent of cirrhosis. Now, as you can see with stage 4, you can see that there is blue staining in the slide here, but you can also see this nodule, which is what I mentioned before. So these nodules is what creates that quote unquote bumpy liver. And that can also be seen on pictures such as ultrasound or CT scan, such that you don't always need a biopsy to confirm the diagnosis of cirrhosis. It can be diagnosed when you start to develop these nodules on imaging. So again, just to look at it in kind of a bit more expanded view, this is a normal liver. Normal liver is nice and smooth and brown, and this is a cirrhotic liver. You can see all these bumps. These are the nodules which have occurred due to the formation of severe scar tissue. So now, what causes cirrhosis? In the United States, there are 3 predominant causes, which are really in this order that I'm putting here. And then there are more rarer causes, which I won't go into in a lot of detail, just because that really requires its own talk into it in and of itself. But I do want to go into the 3 primary causes of cirrhosis in the United States. So the number 1 cause of cirrhosis in the United States, unfortunately, is alcohol use. And that seems to have increased over the last 10 years. There's several possible etiologies for it. One, actually, based on a study that was published by a friend of mine, it may have been traced back to as far back as the recession of 2008. But then more recently, with the COVID pandemic and people having to isolate, that has also led to an increase in alcohol use. And what's important to understand is that alcohol use may be different to different people. So, for instance, for me, I don't drink any alcohol. So for me, 1 drink a day would be too much. But many people, they come home from work after a hard day and they say, well, I just have a 6-pack of beer to relax, or I have 3 or 4 glasses of wine with dinner. And that doesn't seem like anything. But the problem is that it's not so much how much you are drinking, but it's also how much the patient is drinking in correlation with how well the liver repairs itself. So that's why it's important to understand that there isn't really much leeway in terms of how much a patient can drink once they've been diagnosed with liver disease. Once you've been diagnosed with liver disease, because I get this question often, patients say, can I still drink? Or what if I have an occasional drink on the weekends or something like that? And my answer is I strongly advise against it, because of the fact that, again, it's not so much the alcohol use in terms of quantity, but it's also the reaction of the liver to the alcohol. So I want everyone to keep that important point in mind. Next is non-alcoholic fatty liver disease. This is being seen more commonly. It was a disease of the elderly, but now we're also seeing it in young patients, even children. And this is related predominantly to a combination of diabetes and obesity, what we call the metabolic syndrome. The way that it's dealt with, if it's caught early enough, is a combination of diet and exercise leading to weight loss. And then viral hepatitis, of which predominantly there's hepatitis B and hepatitis C. Both of these, fortunately, have very good treatments available as long as the diagnosis has been made early enough. So alcoholic liver disease, I mentioned before about the increase in alcoholic liver disease, and this was a nice study which was published in the British Medical Journal and then was also featured in the New York Times. And what I think is interesting to point out is that what this graph shows is that alcohol use disorder as well as alcohol-related cirrhosis has increased in the United States between 2008 to 2016. That's something I already discussed. But if we look here at the column on the left, these are patients aged 25 to 34. And what you can see is that the greatest increase in both alcohol use disorder as well as alcohol-related cirrhosis has occurred in this age group. And this is very consistent with what I see and probably what Dr. Gish and Dr. Khan see as well in the hospital, is that a lot of these patients who have severe alcoholic liver disease or liver failure are really young. They're presenting in their 20s or their 30s. In terms of what's considered excess or heavy alcohol consumption, my opinion is no alcohol is good alcohol. Again, I don't drink any. But if you look at some of the NIH guidelines, all alcoholic drinks, whether it's a can of beer versus a glass of wine, all of it is 14 grams of alcohol. So there's really no quote unquote safe alcohol. What's determined as alcohol use disorder if it's greater than 4 drinks daily or 14 drinks weekly in men, or greater than 3 drinks daily or 7 drinks weekly in women. And then there's also this concept of binge drinking, where a person has 4 to 5 drinks within a 2-hour period. I'm sure many people have experienced that. And if you happen to binge drink more than 4 times per month, that also meets the definition of heavy drinking or heavy alcohol use. And again, this is to illustrate that there is no safe alcohol. All alcohol, regardless of quantity, all alcoholic beverages, I should say, regardless of quantity, contain a fair amount of alcohol in them and qualify as an alcoholic drink.
Whiskey has 40%. Wow.
Okay. All right. So now let's talk about non-alcoholic fatty liver disease. So I briefly touched upon this, but again, I do want to expand upon this further because of the fact that it's so prevalent in the United States. It's really becoming, it's clearly the #2 cause of liver disease in the United States, and it may rival alcohol use as the #1 cause of liver disease. And what fatty liver disease is it's as simple as it sounds. It's basically fat infiltration in the liver. Many patients, believe it or not, who have fat infiltration may not have any long-term implications. However, around 30% of the patients who do have fat in their liver develop inflammation, which is also known as NASH. And then if they develop inflammation, a fair number of those patients can end up developing scar tissue and ultimately developing cirrhosis of the liver. So the risk factors related to this include diabetes, hypertension, obesity, all of which are primarily related to lifestyle. There's often a family history as well. There's not a direct genetic link, but there is clearly some genetic component to this. The other thing that's important to note for fatty liver disease is that most of the time it presents with no symptoms. That's one of the challenges I face, is that when I tell a patient about it, they say, well, I feel fine, and when I present the treatment options of diet and exercise, that's the response I get. The treatment is weight loss, and that is the only treatment available. People ask me about, what about liver cleanse or milk thistle or different types of foods or spices? And the answer is really only weight loss. You have to cut calories. In particular, it's recommended to reduce carbohydrates and increase vegetables. Black coffee may also provide an adjunct to help reduce fatty liver disease. And then daily exercise. It's all about reducing caloric intake, increasing caloric expenditure so that you go into a calorie deficit and lose weight. If you do that, then that will reverse the disease. And in fact, studies have shown that if you lose 10% of your baseline body weight, that may even have the chance of reversing scar tissue. In addition to that, vitamin E, which is not something I provide for everybody, but it is a possible supplement, but I would advise that you ask your doctor about it first before taking vitamin E. Finally, viral hepatitis, hepatitis B, and hepatitis C. The relevance to this is because if there is somebody you know who has a diagnosis of either of these diseases, they should absolutely receive treatment for these conditions because the treatments are very good. Hepatitis B is predominantly a disease of patients who have immigrated from endemic areas, which includes Asia, Africa, Eastern Europe, or in certain cases, South America. Some additional risk factors include a history of IV drug use or a history of HIV or hepatitis C co-infection. The treatments, again, are a single pill daily, which I've outlined a couple of them here. And the side effects are minimal. So again, there is zero reason that a patient who needs hepatitis B treatment shouldn't get hepatitis B treatment. And the same thing is hepatitis C. Now, one of the differences between hepatitis B and hepatitis C treatment is that for hepatitis B, the treatment is considered to be indefinite because it's a control of the disease. It controls it very well, but it's not a cure. Hepatitis C, believe it or not, we have cures, and the cures are fantastic, 97%. No longer do we use interferon-based injections. We have 2 medications which are on the market, with one of the medications known as Mavorette, the treatment can be for as little as 8 weeks, and you can have a full cure of hepatitis C. So again, it's very important that anyone diagnosed with hepatitis C gets treated. And recommendations are that all patients, because of the fact that treatment is so easy, all patients above the age of 18 should probably be screened at least once for hepatitis C infection. And that especially includes people who were born between the years of 1945 and 1965. Finally, let's conclude with the stages of cirrhosis. So this is the other important thing with regards to understanding cirrhosis. So cirrhosis, by definition, all that means is that there is scar tissue in the liver, okay? Severe scar tissue in the liver. That in and of itself does not indicate something that is terminal. I have many patients who have cirrhosis, but the liver is functioning well. And therefore, I don't refer them for transplant. In fact, I tell them that you might not even die of liver disease. So that's very important to understand that the word cirrhosis does not equate to a very terminal illness. And how do we determine whether the cirrhosis is terminal or not? That depends on whether we can qualify it or classify it as compensated versus decompensated. So to make it kind of simple, compensated cirrhosis is when you have a diagnosis of cirrhosis based on biopsy or based on an ultrasound or CT scan, but there's no development of symptoms. If that's the case, then odds are the patient has compensated cirrhosis. And as long as they are dealing with the insult to their liver, they can remain in compensated cirrhosis. So for instance, if they stop drinking alcohol, if they lose weight effectively, if they get hepatitis B or C treatment, that would prevent their liver from further deteriorating, and then they can remain in compensated cirrhosis and really have a full lifespan. Decompensated cirrhosis is when symptoms do develop. That includes bleeding from your esophagus, ascites fluid, which is basically fluid buildup in your abdomen, or hepatic encephalopathy, which is mental confusion. And in those cases, a liver specialist should always be consulted because that's when a patient may need transplantation. And I appreciate, again, this invitation, and I thank everybody for their attention.
Great. Thanks, Dr. Sundaram, for that great presentation. We're going to transition next to Dr. Jeffrey Kahn. We're going to have our Q&A session at the end. I think there'll be a chance for both verbal Q&A, but definitely using the chat. Vera can help direct you about that. Dr. Kahn is Associate Professor of Clinical Medicine and Medical Director of the Liver Transplant Program at the Keck School of Medicine at USC. He had his fellowship training in gastroenterology and transplant hepatology, also at USC and Cedars-Sinai. He's board certified in internal medicine, gastroenterology, and transplant hepatology, and has major research interests in liver transplantation, liver cancer, viral hepatitis, co-authored many abstracts, peer-reviewed articles in the space of hepatitis C, liver transplantation, and a distinguished lecturer. Jeffrey, please lead the way into your space and education on liver disease, cirrhosis, liver health, and we'll have a great Q&A at the end. Thank you.
Can you guys see my screen?
Yes, we can.
Screen and audio.
Wait, okay, sorry, got ahead of myself. So I want to thank Farah and the foundation for inviting me to speak here. There's really nothing I enjoy more than talking to patients and, patient caregivers and people that are just interested in liver disease, not necessarily physicians who take care of patients with liver disease. And a big interest of mine is actually wellness and cirrhosis and trying to make patients feel better. But I sort of have a second agenda here tonight. I was thinking that patients often come in and ask me these 3 questions. What is this? Why am I doing this? And how does this work? So I was hoping to incorporate these questions and some answers to questions and some specifics about this into my talk. So I wanted to start out just really going through different, issues that patients have and sort of how to address the issues and try to make them feel better. Fatigue is, I think, by far the most common complaint, not really complaint, side effect of or symptom in patients with liver disease by far. Almost all advanced liver disease, I should say cirrhotic patients. And as the cirrhosis advances, the fatigue tends to get worse. There are many reasons for the fatigue. The liver disease itself can cause changes which can cause fatigue. Our patients, especially as their liver disease advances, tend to be in a catabolic state. So they're actually breaking down muscle. So their muscle mass is decreasing. Many of our patients with fatty liver actually have fatty muscle, and the muscle strength may be low. And so patients could be frail just on the basis of poor sort of muscle function. Our patients become encephalopathic, which is confusion. And a lot of our patients with very early confusion complain of severe fatigue. I have this sleep a little bit later, and a lot of our patients have a reversal of the sleep-wake cycle, so they don't sleep well. They try to nap during the day, and it becomes sort of a vicious cycle. And a lot of our patients eventually just can't get out of bed very well. We know that people with low physical activity tend to feel tired. We need to balance low physical activity, increasing the activity, but not so much that our patients actually feel so exhausted that they just can't function. Diet is very important. We used to think, keeping the protein down is a good idea. Now we don't think so. Making sure that patients just eat well. And then I think a huge thing is actually, a huge issue is depression. And, I always tell my patients and their families with more advanced liver disease that it's very normal to feel depressed about the situation. And I think if we can sort of make people feel better by working on symptom control, we can actually maybe improve that depression, because we know that certainly people that feel positively about their health certainly do better. And with liver transplantation and really access to excellent medical care, our patients should do very well. And some people will need a transplant, but hopefully if they don't need one, or they don't qualify for one for some reason, or they're waiting, we still can make them feel better. So first I want to talk a little bit about working out. And I want to just clarify from the beginning, anything I'm going to talk about is sort of in general terms. And I think that everybody who is thinking about doing anything that I'm going to mention should talk to their physician or their provider before doing anything. I recommend either no weights or very light weights. I have a picture coming up, and I'll tell you why I'm showing this in a second. We do know that physical exercise, even without weight lifting, actually increases the pressure in the veins that go to the liver and could increase the risk of bleeding. So we would like all of our patients to seek appropriate treatment for varices, which are those veins in the esophagus that can bleed. And in some cases, the patients undergo band ligation, which is putting little rubber bands around them to prevent bleeding, if they bled before, to prevent them from bleeding again. And then these drugs called beta blockers, which help decrease the pressure as well. So again, part of the sort of total care of the patient is making sure that they're healthy enough, well enough, and in good enough shape to actually embark on exercise. There are many implications to exercise that actually can be improved upon. Certainly cardiovascular endurance, very important. Sarcopenia, which is that muscle wasting. blood sugar control. We know that when patients exercise, their insulin works better. Their sense of balance. We know that our patients often have problems with clotting, they can bleed, and patients can fall and hurt themselves. And so if patients exercise, they tend to walk better, they tend to stand better, they tend to be less frail. Sense of well-being. We all know that exercise increases, endorphins, and we feel good when we exercise. And I think a huge part of exercise is actually the feeling of independence for both the patient and also the caregiver. And I think a patient who is in better shape decreases the likelihood of caregiver burnout, which is of course a big issue. The reason I'm showing this is I actually had a patient who I was actually getting ready to place on a liver transplant list, who told me that he was deadlifting 300 pounds. And so this is sort of a part of a deadlift. And deadlift, any kind of lifting of weights, especially more than a couple of pounds, is probably not a good idea, because again, lifting weights can actually increase abdominal pressure and increase the risk of bleeding. Also, a lot of our patients have umbilical hernias and other kinds of hernias, and certainly increasing that pressure can increase the risk of the hernia either popping out or causing problems. This is actually a study, and I'm not going to go through this, but this just sort of shows you that as you decline in functional status, the sort of interventions that you probably are going to be able to do sort of change. So early on, patients with well-compensated cirrhosis, which means that their liver is still functioning quite well, can often, do similar exercise to other people. As time goes on, maybe you're just doing very, very light weights, just some sort of chair dips to kind of increase maybe, arm strength, some light resistance bands to kind of increase muscle strength, and maybe some very, very light squats, which is just one of the exercises that we do. And then later on, really just balance and strength and trying to get people to be able to walk better, stand better. And there are different things that can be done to try to, improve the ability for patients to do these exercises. I highly suggest working with some sort of a trainer or maybe a physical therapist, occupational therapist, to get a routine down. And then certainly the benefits are, number one, making somebody feel better, making somebody healthier. And if we're talking about liver transplantation, there's a lot in the literature about the fact that people who are very frail, number one, going into transplant, have a lower likelihood of actually getting a transplant because they tend to get sick before they get their transplants. And there's increasing data that people who actually are less frail do better with transplants. They get out of the hospital faster, they get out of the ICU faster, and they just do better. So I think it kind of makes sense. This is actually something that was interesting. This is a sports medicine, College of Sports Medicine. And they just came out, and I think the link is down here with some tips for people that have chronic liver disease in terms of exercising. And I think this is sort of interesting. And again, I'm going to post these the slides if anybody's interested. It's worth taking a look. And these are just some of the things that they talk about. Again, every patient's a little bit different. I'm not sure some of these sort of weight pictures is probably a great idea, doing overhead weights. This looks fairly healthy. I mean, fairly heavy. But again, I think you probably get the idea that some degree of exercise, some degree of activity is very important. Eating healthy is extremely important. We know that if we don't have enough dietary intake, the patients don't do well. And there are many reasons that patients might not have good dietary intake. Cytokines are actually these substances that are produced by white blood cells and other tissues that actually can result in a poor appetite. It actually makes us not feel hungry. It's one of the reasons when we're sick, if we have the flu or we have some other, a viral infection or bacterial infection, a lot of times we're just not hungry because our body's making substances that sort of make us not want to eat. Ascites, which is the fluid that builds up in the abdomen, and going back to Dr. Sundaram's the Greek meaning, so it actually means bag or sack. And as many of you know, that's fluid that builds up in the abdomen. And that can make people feel full very, very early after they start eating and not get enough nutrition. And if people are confused, they probably don't eat very well when they're confused. Our patients tend to have bacterial overgrowth, which is bacteria in the intestine that shouldn't be there, and then things don't get absorbed very well. For patients with, this should say PBC and PSC, actually, two of our diseases that cause, that are what we call cholestatic liver diseases, cause fat and vitamin malabsorption, and that can cause a lot of problems for patients. And then patients can have something called portal hypertensive enteropathy, where the intestines kind of get inflamed and things may not absorb very well. And most of our patients are in some sort of a hypermetabolic state, so they actually need more calories and they need more protein because their muscles breaking down. We want to prevent that, because if our muscle breaks down, obviously we're going to have less strength and we're going to be more malnourished. I'm just going to show this quickly. So there are various ways that we can sort of approach the patient with the dietary needs of the patient with cirrhosis. We have all of our patients see a dietitian. They go through various tests to see whether or not they actually, or what kind of diet they should actually be on. It's very important to assess for dry weight, because we know that about 20 or 30% of patients who have excess fluid in their abdomens and excess fluid in their legs can be actually misclassified as being either obese or severely obese or even overweight. And so somebody can think, oh, your BMI is 30, you're obese, but actually the BMI dry weight might be 22, and that actually is normal, or they could even be lower than that and be actually underweight. So that's really important. In terms of even patients that aren't actually exercising, this just shows you the energy expenditure for sort of normal things that people do. And as we expend energy, that's very, very good for our bodies, as long as we're keeping up with the nutritional needs of our bodies. So everybody doesn't need to be, lifting light weights or doing squats or doing yoga or doing Pilates or whatever. Just cleaning, going grocery shopping, sweeping, and even eating, believe it or not, expends energy, and that's good for our bodies as long as we keep up with it. This just shows sort of recommendations for patients with cirrhosis. I think the most important thing here is that a patient with cirrhosis, especially with fluid buildup, should be on a 2-gram sodium diet or less. Less than 2 grams tends to be unpalatable, and that's why they kind of came up with 2 grams, which is actually less than a teaspoon of salt that somebody should be able to eat in the whole day. And that includes what's in their food. So obviously, if somebody's adding salt, that's not a good idea. They're going to be well over that 2 grams, most likely. We want to avoid hypoglycemia. So it's actually a good idea to have more frequent meals. I tell my patients, if they can, to have maybe a light meal or a snack later in the evening, so that they're not, say, going to bed at 9 or 10 o'clock and then waking up at 8 in the morning and having a prolonged period of fasting. And then multivitamins, depending on what the situation is for the patients with PBC and PSC, they have fat-soluble vitamin deficiencies, vitamin A, D, K, and E, and we have special preparations for that. In terms of sleep, sleep is a very common disturbance that our patients have, and unfortunately, it's very, very debilitating for patients. This is kind of our goal, is for a restful night's sleep. Patients often have difficulty falling asleep or staying asleep, and then they're sleepy during the day, so then they nap more during the day. And we know that the quality of life is very much diminished in these patients. We recommend trying not to sleep during the day, which is very easy to say, but if you haven't been if you've been up all night and then you're just tired, it's very hard. But if you take multiple naps during the day and then you try to go to bed at a normal time at night, it's probably going to be very difficult. We also try to recommend to patients not to be too stimulated at night. So using iPhones, using computers, watching TV, try not to have bright things and try not to sort of think too much before you go to sleep. And then I have a lot of patients with obstructive sleep apnea to varying degrees. And sometimes it's not only the patient, also is the person that sleeps in the same room as the patient. So the person in the same room might have sleep apnea and keep the patient up. So excluding, I would say, sleep apnea amongst the family is probably a good idea, and then treating it as necessary. I wanted to talk a little bit about encephalopathy, just because this comes up a lot, and Dr. Sundara mentions encephalopathy. And so I wanted to, sort of incorporate a little bit of why are we using this drug? So lactulose is the most common drug that we use for encephalopathy, at least right now. It's that sweet liquid that makes people bloated. It doesn't cause diabetes. It doesn't increase your blood sugars, but it can be fairly difficult to tolerate. People get bloated. They have a lot of bowel movements. Usually the goal is to have maybe 2 or 3 bowel movements a day. The way that it works actually is it actually gets into the large intestine and it prevents ammonia from being absorbed in the intestine, so it comes out. And if the ammonia isn't absorbed, the thought is that ammonia, which seems to be a culprit in encephalopathy, will be lower, and that the encephalopathy will be less apparent and maybe have fewer times of having encephalopathy, and maybe longer duration without encephalopathy. Also, we know that stool that sits in the colon, there's a lot of bacteria in the stool. There's ammonia that's produced by those bacteria, and then the ammonia can get absorbed. So if the stool is just sitting there, more ammonia is absorbed. So again, by moving the stool through and by acidifying the stool with this drug called lactulose, we can actually decrease the encephalopathy. I find a lot of patients get admitted with encephalopathy and they get better very quickly when we start giving them lactulose. And I think probably a lot of people don't like it and may not take it as directed. I think it's very important to be honest with your doctor or provider. If you're not taking it because you just can't stand it, there are potentially other alternatives, and it's better to be direct with the person that prescribed it than not to take it, because you could end up in the hospital. Another drug that we use is called rifaximin, and this is an antibiotic. It doesn't get absorbed very well, and it actually kills off bacteria that actually produce ammonia. So they have different mechanisms, and they both work very well in most patients. Rifaximin doesn't have a lot of side effects. It also decreases by decreasing the bacterial load in the intestine, it may also decrease the risk of some infections. It's unclear, but anyway, it's very well tolerated. We've been using it for many, many years. And I certainly recommend talking to your doctor or provider about it. One problem is that it's a bit expensive, and a lot of insurers don't cover it, and it's not considered first-line therapy by insurers. But if somebody doesn't tolerate the lactulose or they're still encephalopathic, it's something to think about. Ascites, I mentioned a little bit earlier. It's the number one reason that people with cirrhosis are admitted to the hospital. Forgot the hospital part. Fluid can get infected. People are just uncomfortable. They bloat. They can have trouble breathing. The fluid can get into the lungs from the abdomen and again have trouble breathing. And again, decreased hunger. You get full easily because pushing on your intestines and your stomach. When we take out fluid from the abdomen, we're also taking out proteins, which are important and can make people more malnourished. So our goal is to try to control the ascites. This again is supposed to be a teaspoon, and this is about as much salt as somebody should have in a whole day. And we know that salt intake in patients with cirrhosis and fluid buildup is directly, the weight is directly proportional to salt intake or sodium intake. So the more salt or sodium that people can cut out of their diet, the better. But we don't want them to cut everything out of their diet that's in their food to the point where they're not eating, because then they're going to become more malnourished. So it's kind of a balance there. I wanted to talk a little bit about diuretics, and I will say that people often ask us about, like, why are we using these diuretics? And the idea is that the diuretics that we use, and I just have the 2 most common ones, furosemide, which is sometimes brand name Lasix, and spironolactone, which is sometimes brand name aldactone, are the 2 major drugs that we use. So this is the kidney, and then this is like the microscopic unit of the kidney. And so imagine urine is forming here. It goes through this little microscopic tube and eventually comes out of the kidney into the ureter, and then you urinate it out. Well, the furosemide blocks the salt in one place earlier on from being absorbed back into the body. And that helps to keep when the salt is going out of the body, it's not going to stay in the body, and the fluid buildup is going to be less. As the urine goes along, there's another opportunity for the salt to be reabsorbed by the kidney into the systemic circulation, and the spironolactone blocks here. So it's very, very important to use both of these drugs if tolerated, because they have a synergistic effect. Another thing that comes up, I've had many patients, and I would suspect that Dr. Sundaram and Dr. Gish probably have as well, who tell them or tell me that they're going to see a surgeon because somebody thinks that they have breast cancer. I'll talk about men. And certainly men get breast cancer, and I'm not discounting that. But a lot of our patients on spironolactone in the literature, maybe 15, 20%, maybe even more, develop glandular tissue in the breast. And it can be very tender. And I've had patients that couldn't even put a shirt on because of it. This isn't a great picture because usually it's actually bilateral. And this is just showing it to be unilateral. If you stop the spironolactone, it gets better. And there are other alternatives that we can use to have a similar effect in terms of the spironolactone. So it can be stopped. In the past, people have used tamoxifen, which has an anti-estrogen effect because of the increased, sort of estrogen effects of the spironolactone, but I don't think that's usually very necessary. Patients often complain of headaches, and they say, well, what can I take? And with a normal, healthy liver, the amount of sort of safe acetaminophen or the active ingredient in Tylenol seems to kind of be going down over time. So we don't want patients, actually, this should be 10 extra strength, or about 20, 30, I guess 20 regular strength acetaminophen, or actually this should be 8 extra strength and maybe 15 regular strength acetaminophen in a total in a day, which can cause liver failure even in very healthy people, I should say. And we do know that a lot of people who develop liver failure have what we call therapeutic misadventures. These are healthy people or people with cirrhosis, because what happens is there's some acetaminophen in the Dayquil they took, there's some acetaminophen in the Tylenol they took, and in the NyQuil they took, and the Excedrin, and so it all adds up. If you go to the UK and if you want to get anything with acetaminophen, you have to actually meet with a pharmacist who will go through and have you sign like a waiver basically showing that they talk to you about the different preparations that can have acetaminophen. And the bottom line is if you overwhelm the system that produces non-toxic metabolites, you end up with toxic metabolites. And this is actually worse in people with liver disease for multiple reasons. The liver's not functioning as well. Patients who are malnourished produce more toxic metabolites. People who chronically drink alcohol produce more toxic metabolites. So here's where my 4 extra strength or 6 regular strength in a day, the recommendation is no more than that. We do know that people that even take this amount can potentially have problems, especially if they're doing it on a daily basis. So again, I never encourage people to take acetaminophen, on a daily basis. I think if people have chronic headaches, they probably should see a neurologist or a headache specialist and come up with a treatment regimen that doesn't require these drugs on a regular basis. We don't like non-steroidal anti-inflammatory drugs. And the major reason is, especially in our cirrhotic populations, they can cause ulcers. If a patient has an ulcer and has a bleeding problem, the ulcers can bleed more, they can perforate, and that's a problem. The other thing is that we know that not only do the NSAIDs cause kidney failure in some people, they also can decrease the effectiveness of the diuretics. So the Lasix or the furosemide and the spironolactone may not work as well. And plus, there's a synergistic effect of actually causing kidney problems with those drugs. So we recommend not taking NSAIDs. In terms of the skin, I just have a few things on skin. When patients come in, they often complain of itchy when they have these 2 liver diseases, PBC and PSC. And we don't know the exact cause of that, but I will say that the pruritus or itching of PBC or PSC can be unrelenting. And I don't know if anybody is on here who has PBC or PSC or knows a patient or somebody with those diseases. But I've had patients come in that actually had cut their nails down to the quick because they kept scratching so much they were bleeding. And it's just a very difficult thing to treat. The major treatments that we have are cholestyramine, which is I'll show you a slide in a second how that works and how I use it, and I don't know if others do as well. And then a drug called rifampin, which helps actually increase the movement of sort of toxic substances from the liver cell out into the ducts that drain the liver. naltrexone, which actually has an anti-opiate effect. And there's a belief that maybe some receptors in the brain actually respond to what we call endogenous opiates, which are things like morphine and codeine, but endogenous ones that actually can cause itching. And that if we can sort of block those receptors, we can reverse the itching. We have to be careful, because if somebody's on narcotics for pain, then there could be an issue there, and people can actually end up with narcotic withdrawal from these drugs. And then sertraline, which acts as an antidepressant, but in this case, actually acts to probably blunt some nerves that may cause pain. I will say that a lot of people come in on antihistamines, and I'll say antihistamines don't actually improve the itching, because this isn't a histamine or an allergy problem. But I think some people benefit by taking them, especially at night, because the itching is often worse at night, and the patients actually maybe sleep better, but it doesn't actually make the itching better. I'll also say that for those of you who might be on ursodeoxycholic acid for PBC especially, that can actually cause itching. So if you're on it and you have itching, you probably want to talk to your doctor about it, because it can actually cause itching. So how does cholestyramine work? Well, first of all, I'll let you know that it actually binds something called bile acids and maybe some other things that are actually produced in the liver. They go into the intestine, and then they actually get absorbed later, lower in the intestine. When they get absorbed, things can build up and people can develop itching. It's much more complicated than that, and there are probably other things involved. But at the end of the day, if we bind bile acids with something called cholestyramine, or what we call bile acid sequestrants, we can actually decrease itching. And what I'll tell you is that if you think of the bile acid level like a swimming pool, and if you can get the level of the water in the swimming pool down below a certain level, that every patient has their own, what I call itch threshold, then you can actually make the itching either disappear or much better. But it usually takes sometimes weeks to work, because you have to get the level of these bile acids down, which again, I'm analogous to water in a swimming pool. What I ask patients to do is to mix 4 grams of cholestyramine in 8 ounces of liquid. And then if somebody has a gallbladder, I want them to drink half before and half after breakfast. The reason is, if somebody's fasting overnight, their gallbladder contracts right when they start eating, you're going to release bile into the intestine before you've actually given the drug. So you're going to lose a lot of the bile, and you're going to lose a lot of the anti-itch effect. And then I have them repeat the whole thing after lunch. If somebody doesn't have a gallbladder, then they can just take the whole thing after they eat breakfast and lunch. And you want to have importantly have a 3-hour-ish window before taking other medications, especially ursodeoxycholic acid, because it binds them and could actually nullify the effects of some medications. Just a couple of other skin things, what people call liver spots, people come to me all the time, have nothing to do with the liver. These are usually kind of age-related spots, and again, nothing to do with the liver, and I wish they would change the name of liver spots. Some things that we do see commonly, something called vascular spiders or spider angiomata, which kind of have a spidery appearance, and these form in people with liver disease, probably due to sort of blood shunting of blood, and probably things like estrogens and things that probably end up not being cleared in the liver, or perhaps things that aren't produced by a normal liver that actually can prevent these things. Again, it's not 100% clear the only reason that the patients get this, but they're very common in our patients, in some series up to 80% of patients. They often disappear after transplant. I'll mention some people have almost a mass, kind of effect on their skin, and it can actually, don't pick at it because it can actually start bleeding. Palmaerythema is actually the redness that occurs on the palms. And it tends to be more on this side of the palm, which is like on the pinky side in some patients. But regardless, though, usually there's clearing in the center. Many people have red palms. We're going to see this kind of appearance, or this is a little bit less pronounced. That's very common in people with cirrhosis. Terry's nails is these nails where the nail beds are white. There's a sort of brownish sort of tint here. It's actually not the nails, but it's actually the nail bed, or it's the tissue below the nail that changes due to chronic liver disease. People used to think it's due to low albumin, but it's actually not. clubbing of the nails, which is where this sort of raised appearance of the nail can occur in people with really any liver disease, oftentimes in patients with liver disease related to lung disease related to liver disease, and can cause a sort of raised appearance in the nail bed. And this can improve after treatment for these things or after liver transplantation in some instances. These are called xanthelasma, which are these whitish kind of deposits of cholesterol that occur especially in PBC. Patients often go and have these lasered and they come back. They do go away most of the time after transplant. Sometimes treating with anti-cholesterol drugs can help. And unfortunately, I know that they're kind of not very nice looking and people get very upset. And I've had patients that just wear dark glasses because they don't want people to see their eyes. And I wish we had a better treatment for them. Just a couple of other things, Raynaud's phenomenon, which is when patients actually, or people put their hand in a cold area, their fingers can turn, part of them can get redder, some can get whiter, and oftentimes they turn blue. You don't have to have liver disease to have Raynaud's. I actually have Raynaud's, and it can be very debilitating because your fingers get numb, they hurt, and basically, if I go out in the cold, my fingers can look like this sometimes. And then something called vitiligo, which is a loss of pigment, usually seen in autoimmune diseases or sometimes seen in nothing. But in our liver disease population, we often see this in primary biliary cholangitis and occasionally in autoimmune hepatitis. So that's the end of my presentation. I just wanted to present kind of a hodgepodge of things related to cirrhosis, and I'll get rid of my screen share here.
That was a wonderful hodgepodge, Dr. Khan. It's fantastic, much appreciated. Really want to thank you and Dr. Sundaram for your wonderful presentations today. Thank you for sharing your slides with our foundation for future shares, of course, in education, as well as being recorded. And there are a number of questions that have come through in the chat, and really want to go to some general topics here. Number one, let's start out with that big question about the confusion about LFTs. I have many patients who come to me and say, my provider said my LFTs are bad, I think I'm dying. And I say, well, your function's normal, but it's your enzymes that are abnormal. How do you communicate that? Jeff, we'll start with you, and then Vinay, let's go to you next. Dr. Khan, how do you communicate the difference between enzymes and function and get rid of this old LFT term?
Well, I'll tell you, when my fellows and residents come on the service, the first thing that I tell them is that I don't want them to say LFTs, unless they're specifically talking about things that affect liver function. The way I describe it is, the AST and ALT can be elevated, and those are two things that a lot of people call LFTs. But you can have elevations in people whose liver is functioning normally, or you can have almost normal levels in people whose livers are functioning very abnormally. So I like to sort of tell the patients the things that are really about the liver function. I look at the albumin, I look at the bilirubin, I look at the prothrombin and INR, which are really effects of clotting factor deficiencies. If we look at MELD score, which is something that we talk about with liver transplantation, we talk about creatinine, how the kidneys are functioning. And then there's some other sort of provocative tests. But when patients come in and say, oh my gosh, my AST went to 90, and they get all nervous, I said, yes, but your bilirubin is 0.8 and your albumin is 4. Your liver function is excellent. So it's challenging, but I think educating the physicians and providers out there is maybe the first step.
That's a fantastic response. Absolutely 100% perfect. And Vinay, let's go to that worst of all liver function tests, the serum ammonia testing. I get a text from the family, my mom's in the ER, they're checking her ammonia test. And I said, did they do a physical? And the answer is usually no. And they just rush off to do lab testings and forget the most important thing, which is physical. Do you use ammonia, or if you don't, how do you get your ER doctors and your hospitalists to stop checking ammonia levels?
Yeah, and it's not just a problem with the ER and the hospitalists. It's a problem with the primary care doctors. It's a problem even with certain gastroenterologists. And, it's a real difficulty because it just leads to misinformation and just unnecessary distress for the patient. I think so. The first thing is you have to have a discussion with the patient about the value of the ammonia level and what the ammonia level actually tells you, which, I explained that from the perspective of hepatic encephalopathy, the ammonia level really doesn't tell you anything. And I don't go into the details of, it has to be an arterial stick, has to be on ice. I don't bother them with that. What I do explain is that essentially, to try to simplify it, I say that ammonia does lead to encephalopathy, but it's essentially ammonia that gets into the brain. I mean, scientifically, it has to cross the blood-brain barrier and leads to astrocyte swelling, but that's not a patient conversation. So I say that, the ammonia level measured in your blood, it doesn't correlate with the ammonia in your brain, which is why we determine hepatic encephalopathy or confusion based on a clinical diagnosis. And that's where it's important, where you have to pay attention to see, do you know any changes? And if family is with the patient, I also tell them, you also have to pay attention if you notice any changes, because if somebody gets confused, they may not even be aware of that. They may not tell you, I feel confused. You also have to pick up on that. And if this confusion or, change in mental status seems subtle, then that's where you would need to ask how many bowel movements has the patient had, and if it hasn't been enough, increasing lactulose or giving more lactulose on an as needed basis. And then if the confusion becomes moderate to severe, where there's development of disorientation or sleepiness, then that should be a visit to the emergency room. But that's kind of the way I start with that ammonia issue is I always start with the patient. In terms of providers, I mean, they're going to do what they do. I've found that you can educate referring physicians, but I mean, it sometimes it really feels like it's swimming up a current. I mean, it's just somehow been so ingrained. I don't know why, because when I was in medical training, it really wasn't considered to be so important. But I guess maybe prior to when I was in training, it was just so deeply ingrained that a lot of people haven't stopped it. Certainly with all of us are in teaching hospitals. So I certainly emphasize with every graduating fellow resident, the lack of importance of it. I mean, and really it has a very minimal utility. Only in the setting of acute liver failure is it really something that's going to be useful. But in the patient with cirrhosis, with concerns for hepatic encephalopathy, I just emphasize it as a clinical diagnosis.
Great answer. Let's go to another sort of misterminology. And you did a great job moving from alcoholic to alcohol use disorder or alcohol associated liver disease. We're really trying to get that word alcoholic out of our lexicon, out of our terms we use with our patients, because it's so stigmatizing. Mm-hmm. I'm going to go back to you, Dr. Khan, first, and then you, Vinay, is that how do you get rid of this word alcoholic, both in NAFLD, which still has the word alcoholic in it, and also when you've got the patients in front of you to deal with their liver disease, which might be a mixture of different things. Dr. Khan, you go first. How do we get rid of the word alcoholic from our terminology?
I think probably educating, the physicians, the advanced, the advanced practitioners, and really just the medical community, right? So I think, as you said, it's very stigmatizing. And, if you label a patient as being, having alcoholic liver disease or alcoholic hepatitis, it's sort of, you're not only telling them that they have a serious disease, but then you're sort of adding an extra stress on them, which makes them feel like, they're pariahs in society, which isn't the case. I mean, I think somebody with alcohol-related liver disease has two diseases, right? They have alcohol use disorder and they have liver disease. I think, the mental health, professionals are much better these days at doing that. I think certainly hepatologists, I don't know any hepatologists now who say alcoholic hepatitis or alcoholic cirrhosis, but I suppose some people probably do. So we probably have to start with ourselves first. But I think just getting the word out, maybe a good campaign for some of the big, liver societies, stop the term. It doesn't help anybody, so. You're on mute, Bob.
How do we get rid of that word alcoholic, Vinay, in our terminology?
Yeah, I think that is one where we are making some progress. At least when I talk to colleagues, I don't see that term as often. I see more of the term alcohol use disorder, but you are correct. This idea of stigmatizing a disease process is really not productive. One of the first things I say when a patient comes to see me, regardless of the etiology of their cirrhosis, literally one of the first things I tell them is it's not your fault. Because what you have to do is you do have to take away that the issue of shame. You have to, of course, explain the condition and explain how do you get better, but you can't shame somebody into doing that. And oftentimes patients are accompanied by wives, by children, by parents. And in certain cases, it's done out of love, but in certain cases, the family members will kind of will jump on them when you tell them, oh, this is due to because you're drinking too much. Then they'll say, see, why do you have to drink so much? Or, they'll add that component of guilt. So I think it's important to first initiate the conversation by saying it's not your fault, and then moving forward by explaining that when it comes to liver disease, regardless of etiology, there is a component of your own body and your own genetics and how your body reacts to things, and essentially the liver's repair mechanism. And explaining that, unfortunately, we cannot change our genetics. We can only change our environment. And so that's where we have to approach, is how do we change that? And then I move forward in terms of, alcohol reduction or weight loss, et cetera. But I think that's very important, and that also goes into the question of how do we destigmatize the word cirrhosis as well. I think it's very important to clarify to the patient up front that this is not something that is their fault, because blaming a patient for their behavior is not going to make them better, in my opinion. I don't think it shows quote unquote tough love. I think it's just going to put them in a darker state where they're going to be less responsive to the treatment they need.
Fantastic answer. You brought up the word genetics. Let's go to that for a moment. Dr. Khan, when you were seeing a patient and they want to know what's the genetic influence, or could they have a genetic disease causing their liver disease, if you could talk about maybe iron and alpha-1, but what are the genetics of fatty liver?
I think the genetics of fatty liver are really multiple genetics. I mean, there are multiple sort of, people from, various ethnicities and even races, which actually have a predisposition to actually more fatty liver or less fatty liver. And I think, we tend, certainly here in Southern California, to talk about Latinos with fatty liver and genetics there. I think we look at people from Asia, where we talk about fatty liver. These are people that tend to have a lot of what we call visceral fat, which is the fat that's on the inside that you can't see, even though you don't see it on the outside. And I think the genetics in various groups is actually very, very different. As Vinay said, though, regardless, you also don't want somebody to sort of blame their families for causing their liver disease. So I think we have to be a little bit careful. But I will say, I have many patients that come in with fatty liver. I saw one in my clinic yesterday, thin, strong family history of fatty liver disease, and really very little obesity in the family, non-diabetic. So it's very, very confusing, and it's very, very, difficult. And it may be like other kinds of diseases where the genetics may inform how we're going to treat patients. I think Vinay had mentioned, drugs that are going to be coming out for fatty liver, and some drugs may be better for some patients with different genetic profiles than other patients. So I think they may actually be sort of profiling how to treat diseases based upon the genetics. Very, very complicated. So
that's a great answer. And I do think we're talking to the patients with this discussion. So I want to thank you for keeping it simple. Now, Vinay, you were talking about alcohol and all these different complex parts of alcohol. Genetics come into this alcohol use disorder. Do you discuss that with your patients?
Not in detail. I do discuss a couple of components. I ask them if they have a family history of alcohol use disorder. Oftentimes the answer is yes. And that leads me to segue into a discussion about the fact that, again, it's not your fault. Again, explaining that alcohol use disorder is not a matter of about lack of willpower or a conscious decision, but rather it's a disease addiction. It's a disease related to addiction, which is the same as any other disease that we deal with. It's a medical condition. And And, in terms of also genetic predispositions to developing liver disease in relation to alcohol, I don't go into genetics per se, but I do go into the notion of that, everybody's body reacts differently to something such as alcohol. And I often use the example of, I bet you have friends who drink more than you do and they don't have any liver problems. And I always get a smile and a nod, yes. And I say, well, and I explain to them, that's because your liver is just more sensitive to alcohol than theirs is. And then I move into the fact that based on that sensitivity of your liver to alcohol, that's the reason why alcohol needs to be stopped, because of the fact that we know that your liver is sensitive. And so that would lead to the potential for liver deterioration.
All right, we're actually over time, but I think that's acceptable. There's still a lot of people online. Farah, should we wrap up or can I do one more question?
Oh, please, if you have one more question, yes.
So there's this whole issue about nutrition, which both of you did a fantastic job of covering, especially in patients with cirrhosis. There's this, I keep seeing patients who are on magnesium oxide and their magnesium levels always low. I always use a different magnesium compound, and I'm building that magnesium into a zinc and vitamin A and vitamin D. Those are the 4 nutrients I measure in all of my patients with cirrhosis. And in fact, everybody with alcohol use disorder and alcohol-associated liver disease. What do you all do for your supplement recommendations? Are you in the A, D, zinc, magnesium world? And am I missing anything else we should be measuring?
Part of it, I think, depends on the liver disease. So, I had mentioned PBC and PSC, and these patients are often deficient, I find, in vitamin A, vitamin D, and sometimes in vitamin E, and vitamin K as well. And so there's the preparation of the ADEC, which is the form of fat-soluble vitamins, which are the ones that aren't absorbed very well, that are actually better absorbed in people that have sort of fat absorption issues. I think zinc is very, very important. We also want to make sure we don't over-treat with zinc. I think magnesium is very important because patients that are magnesium deficient, if people out there think about like women that go into preterm labor, they give them magnesium because it relaxes muscles. And so patients that are magnesium deficient end up with all sorts of symptoms. But again, we don't want to overdo it, because if the kidneys aren't doing well, the magnesium level can go up and people can get very confused. So I think if we're going to treat for deficiencies, number one, see if the deficiency is there. Number two, don't overtreat and make sure we follow them. People sometimes treat vitamin D deficiency forever, and then their vitamin D level goes to 120 or something. So I think just being mindful of that. So, and the other thing about giving too much zinc can make somebody copper deficient, which can actually cause other problems. So we have to be very, very sort of careful and mindful of how we look at vitamins and supplements.
Great points. Vinay, any wrap-ups on nutrition? Are you in the cirrhosis diet where you're giving your patients 6 snacks a day and lots of carbs?
Yeah. So here's some of the things I do. One is I am a fan of vitamin D. Even beyond the PBC, PSC, I find a good number of my patients with cirrhosis are vitamin D deficient. I do screen for vitamin D levels routinely, and I do advocate for a vitamin D supplement. I haven't found patients who've had, very high levels of vitamin D. There was a recent paper that was published that says that falls are common in patients with cirrhosis, and furthermore, as the cirrhosis population is becoming more elderly, these patients who fall, they are also at risk of developing osteoporotic fractures. So that's where I do think vitamin D supplementation is useful. I like magnesium as well. I don't give it routinely. I do give it for patients who have muscle cramps. I find that it works pretty well. And then, in the patients with cirrhosis, it's hard for them to adhere to the frequent meals with snacks. I tell them the high protein snack at night, which is based on data showing that it increases muscle mass. I also advise shakes such as Ensure or Boost or whatever, which are high protein shakes. And I tell them not to use that as a meal replacement, but rather as a meal supplement, because oftentimes these patients are not eating adequately. So that, if you tell them you supplement your dinner with an Ensure shake, they're probably eating about a quarter or half of their dinner anyway. So I advocate for that as a meal supplement. I do think protein calorie malnutrition is prevalent. So again, I advocate for protein among patients with cirrhosis. And the final thing, which I know Jeff provided a lot of information on, is exercise. I do think exercise is important. I'm certainly don't advocate for heavy lifting, but it is important to know that especially as a patient develops cirrhosis, and particularly if they develop ascites, there is a risk of atrophy of the quadriceps and of the gluteal muscles. That affects the ability to ambulate. That even affects the ability to stand from a sitting position. So I explained to combat that I recommend daily physical activity. Many of these patients are really sedentary and they don't even realize how sedentary they are. And they also don't realize how active the human body is supposed to be. As humans, we are actually, as hunter and gatherers, we are meant to walk 3 to 4 miles a day to find our next source of food. We don't do that anymore because you can press a button on your phone and get food delivered to you. So, so as a result of that, that's the final component of the kind of my nutrition and lifestyle recommendations.
So that's a great wrap up. Our patients do want to hear about nutrition. They want us to talk about nutrition. Of course, all my patients take their cup of coffee with their pravastatin every day, especially my cirrhotics, but we can talk about that next time. Thank you both for joining us.
I tried on coffee actually, because when I ask patients if they drink coffee, they're usually afraid I'm going to tell them to stop drinking their coffee, and they get really excited when I say, no, that's fine, that's good for you.
Fantastic. And if they're from Asia, tea is almost as good, right? So we like that. All right, thank you both for joining us. This is a fantastic session, incredibly good presentations, and great engagement for our Q&A. Vera, I'm going to turn it back to you for a wrap up. And thank you, Phil Black, for joining us and supporting us, and Exelixis, who was sort of here, but they definitely gave us support. Thank you. Great evening.
Well, first of all, I want to remind everybody that today is National Doctors Day. So, happy National Doctors Day to all of you. Thank you for saving lives every single day. We really appreciate it. And thank you, Dr. Vinay Sundaram, for your presentation and your time. Dr. Khan, thank you for your time and presentation. And also, Dr. Gish, thank you for being a wonderful MC. I love the conversation at the end. We got good response on that from our audience. We thank Exelixis for their continued support of Liver Health Foundation, and AbbVie for supporting this program. Please visit our website at liverhealthfoundations.org. And we are on all social media. Please visit. We post a lot regarding our events. So this is the end of program tonight. This was a wonderful, fascinating program, especially the Q&A session. Thank you again to our doctors. Happy National Doctors Day to all of you. And we'll see you middle of April. Thank you.